Take 5 seconds to pause the video and read the question, and then we'll go through the answer. Okay, so we have a 14-year-old male coming to his pediatrician with his father for shortness of breath and fatigue. No significant past medical history, although his father has a history of asthma, okay? His father denies any family history of heart disease or sudden cardiac death. That's important, okay? So we're thinking about things like Hocum or Brugada syndrome potentially. The patient states that he has felt winded with activity over the past week. According to his father, the shortness of breath became particularly bothersome during football practice. So we know that it's worse with activity. The patient also reports a mild erythematous rash on his forearm that resolved within 3 days. The rash was first noticed 2 weeks earlier when on a hiking trip with his family. The patient denies any chest pain, nausea, and diarrhea. Vital signs are shown below. EKG is shown. Temperature is not, we don't have a fever, but it's interesting. It's a little high. Heart rate is 30, okay. Blood pressure 74/44, respiratory rate's 18, oxygen's 94% on room air. It's, these are somewhat alarming. So there's definitely something going on here. Let's take a look at this EKG. So yeah, so this is pretty interesting. So heart rate is 30. That's very, very low, very abnormal, right? So you can see between this R wave and this R wave, there's about, let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yeah, there's like 10 to 11 boxes between these R waves, but the actual R intervals are actually pretty regular, okay? And then we can see these P waves here. If we're just looking at the P waves, so the P waves, this would be the next thing I'm kind of looking at. So these P waves, yeah, these are all pretty regular intervals between these P waves. You have to be careful for the T waves, right? So you don't want to confuse T waves for P waves. So I think here's a really good depiction of, there's like an overlap of a T and a P wave here. So I know there's a P wave here, P wave, P wave, P wave, P wave. So, the intervals between the P waves are actually pretty regular, and the intervals between the QRSs are also pretty regular, but there's really no association. You can see here, there's really no association between the P waves and the QRSs, right? They're completely different in each of these R waves here. So this is what we would call a third degree AV block. Okay, and I think it's really well depicted down here. So you can see every time there's a P wave, you can see they have a marking here for each P wave. And then you can see every time that there's an R wave, you can see the R waves here, and you can see that there's really no clear connection between the P waves and the R waves. And so yeah, this would be a third degree AV block. Okay, so we know, let's just write that down. So we know that this patient probably has a third degree AV block. Now, the question is, why does a 14-year-old have a third degree AV block? Really no significant family history, like we mentioned. If we go back to this mild erythematous rash on the forearm from a hiking trip that now resolved, and now the patient has, not necessarily a fever, but, slightly high temperature. They have what looks like an AV block. I'm starting to think a little bit about Lyme disease, or maybe like a Lyme carditis type picture. But let's just go through the options here and see if we can get some more information. So the first option here, inhaled short-acting beta agonist. So this would be, like an albuterol nebulizer, something like that. If this patient if we suspected they actually had asthma and that was the cause of their shortness of breath. But I think we definitely have enough information from this EKG alone to say that it's not just asthma that's causing this patient's symptoms. I definitely see here in V6 a very clear depiction of what looks to me to be a third degree AV block. So I don't think that would be the correct answer. I don't think that's going to make a huge difference in this patient at this moment, especially because the heart rate's 30. B, transient hyperpolarization of cardiac nodal cells. Remember, if hyperpolarizing the nodal cells like the AV node, would you want to hyperpolarize the AV node in the setting of an AV block? Probably not. You don't want to make it so you have, longer refractory periods in the AV node. What typically would do this? What would cause a transient hyperpolarization of cardiac nodal cells? That's going to be very classic for adenosine, right? Adenosine does that, for 15 seconds or so, very short acting. It causes, remember, it acts through the GI pathway, stimulates the GI pathway, and increases potassium efflux, okay, to cause hyperpolarization, as well as decreasing calcium current at the L-type channels in nodal cells. Okay, remember, that's what adenosine does. All right, let's do option C here. Inhibition of sodium-potassium ATPase in myocardial cells. What does this? This is going to be digoxin, right? Digoxin is going to do this. It's going to inhibit the sodium-potassium ATPase. You're going to get a buildup of sodium. That buildup of sodium is going to get exchanged for calcium. So you get increases in calcium in the non-pacemaker cells. So you get increases in calcium in non-pacemaker cells. Okay, so it sounds good on paper, like we said, but it's in non-pacemaker cells. This is in the ventricular cells. That increase in calcium in ventricular cells is associated with increased contractility. Remember, ventricular depolarizations are not the same as AV nodal depolarizations. Ventricular depolarizations use sodium to conduct phase 0, whereas the nodal cells will use calcium. So don't get that confused. So digoxin does not help increase the speed of depolarizations in nodal cells. It actually slows it down because it increases parasympathetic activity. So digoxin is in your category of AV nodal blocking agents. Just remember that, even though it increases contractility. Okay. All right. D, inhibition of cardiac L-type calcium channels. This is not correct, right? This is going to be something like diltiazem, verapamil. They're going to inhibit the cardiac L-type calcium channels. That's going to slow the depolarizations at the AV node. We don't want to slow them anymore, right? The AV node, right? If we look at this, the thing that's conducting the atrial potentials here, the P waves, the thing that's conducting these is the SA node. But the thing that's conducting the ventricles is not the SA node. There's no signals getting through the AV node. That's what a third-degree block is. In this case, because the rate is 30, it might even be the bundles, right, that are actually pacing the heart at this point. Okay, so you don't want to slow things down at nodal cells. That would be a very bad idea. So B, C, and D would be very bad ideas in this patient. Okay, now E is interesting. Irreversible inhibition of bacterial cell wall synthesis. What does that have to do with a third-degree AV block? Well, think about a drug that might do this, that might help your cause here. Now, if a patient, typically when you're thinking Lyme disease, you see a patient that has a rash, you think, oh yeah, we probably can use something like doxycycline, for example. But if a patient has neurologic symptoms or cardiac symptoms related to Lyme disease, it tends to up the ante here, and they tend to treat this with IV ceftriaxone. So remember, ceftriaxone is also used to treat Lyme disease in these situations where you have these third-degree AV blocks. So ceftriaxone, being a cephalosporin, is used at its mechanism of action to irreversibly inhibit bacterial cell wall synthesis. That's what it does. So this is tricky because if you just were looking for the right answer, you might have a hard time finding it. But I think if you use process of elimination here, you can definitely get to the right answer. And this is what makes this question so hard, but it's a great teaching point, is because if you understand mechanisms, you can get to answers. Even if you don't know the right answer, even if you didn't know the mechanism of action of ceftriaxone, if you understand cardiac physiology, you can still solve this problem.